Hi, good morning, doctors. Today is a 9th day of reading Oxford Handbook of General Practice, and we will start reading from page number 287. I am Dr. Sesha, your study buddy, first preparing for MRCGP International AKT exam. So here we were reading about COPD and its management, referral for specialist care. When the diagnosis is uncertain diagnosis, age is less than 40 years, severe COPD, rapid decline in FEV1, hemoptysis is an urgent referral, frequent exacerbations, pulmonary hypertension or cor pulmonare, alpha-1 antitrypsin deficiency, assessment for LTOT, long-term oxygen therapy, withdrawal of long-term steroids, long-term nebulizer therapy, surgery, example lung transplant or bullectomy. These are the conditions wherein you have to refer for a specialist care. Long-term oxygen therapy, only prescribed after evaluation by a respiratory physician. Refer patients with severe airflow obstruction, that is FEV1 less than 30%, or consider if 30 to 49%, hypoxemia, oxygen saturation less than 92% in breathing air, cyanosis, polycythemia, peripheral edema, or raised JVP. Treatment for more than 15 hours per day increases survival and quality of life. Ambulatory oxygen can increase the exercise tolerance in some patients. Always warn patients about the fire risk of having pure oxygen in their homes. Oxygen cylinders and associated equipment. Arrangements for supply of oxygen are differ across the UK. See the BNF. Specify the amount of oxygen required hours or per day and the flow rate. Oxygen concentrations are more economical for long-term oxygen therapy. Oxygen concentrators are more economical for long-term oxygen therapy. Supply backup cylinders in case of breakdown or power cut. Prognosis. Poor prognosis is associated with smoking status, whether he's a current smoker, chronic hypoxemia or cor pulmonare, low BMI, multimorbidity or frailty, severe or frequent exacerbations, plus or minus hospital admissions, breathlessness, MRC category 4 or 5, high symptom burden, plus or minus decreased exercise capacity, low FEV1 or meets the criteria for LTOT. Cor pulmonare, page 236, palliative care 1101, 1011, we will read those when we go to those pages. Acute exacerbations of COPD. Risk factors for exacerbation. Exposure to passive smoke, lack of physical activity, viral or bacterial infection, seasonal variation, winter or spring, continuous smoking or relapse for ex-smokers, indoor or outdoor air pollution, example nitrous oxide, ozone. Presentation. Worsening for previous stable condition. Features include one or more than one of the following. There is an increased dyspnea, marked dyspnea, tachypnea, more than 25 breaths per minute, use of axillary muscles as breast and pursed lip breathing are signs of severe exacerbation. Decreased exercise tolerance, marked decrease in activities of daily living as a sign of severe exacerbation. Increased fatigue, increased fluid retention. New onset edema is a sign of severe exacerbation. Increased wheeze, chest tightness, increase in cough, increase in sputum purulence, increase in sputum volume, upper airway symptoms, example cold, sore throat, new onset cyanosis, severe exacerbation, acute confusion, severe exacerbation. Fever and chest pain are common presenting features. Consider uncommon presenting features, and you need to consider alternative diagnosis when you have a COPD patient presenting with chest pain and fever. Differential diagnosis. So, a patient with COPD presenting with any increased signs of exacerbation, you have to see other differentials also, like pneumonia, left ventricular failure or pulmonary edema, lung cancer, pleural effusion, recurrent aspiration, pneumothorax, pulmonary embolism, upper airway obstruction. Investigations. Pulse oximetry can be used to assess the severity. Saturation less than 92% on air suggests hypoxemia. Consider admission. And to monitor progress. Chest X-ray. Consider diagnostic doubt or to exclude other causes or symptoms. Sputum culture not recommended routinely in the community. Rescue medication and escalation plans. Develop an individualized escalation plan with each patient to manage exacerbations. If able to understand their use, Offer patients at risk of exacerbations a short course of oral steroids and antibiotics to keep at home to enable prompt treatment of exacerbations. Reviewing if using more than 3 courses of oral steroids or antibiotics per year. So you are giving prophylactically, you are giving a course of antibiotic and steroids to keep at home, and you're giving them advice as to they will be using it. So if they are using more than 3 courses in a year, then you have to review their primary management of COPD. GP management: decide whether to start treat at home or admit to a hospital. If managing in the community, add or increase the bronchodilators. Consider if inhaler device or technique are appropriate. Oral steroids: start early in the course of an exacerbation. If increased breathlessness which interferes with daily activities, dosage is 30 to 40 milligrams per day of prednisolone for 1 to 2 weeks. So consider osteoporosis prophylaxis with a bisphosphonate if frequent courses are required. So as compared to asthma exacerbation, every case of asthma exacerbation should be given 40 milligrams or 1 milligram per kg body weight up to 60 milligrams of prednisolone for 5 days during an exacerbation. However, in COPD, the dosage is 30 to 40 milligrams per day of prednisolone for 1 to 2 weeks. And then you have to consider osteoporosis prophylaxis if more courses are being given. Deciding to treat exacerbations at home or in hospital, the more features in the treat in the hospital column, the more likely need for admission. So, ability to cope at home: yes, treat at home. No, treat in the hospital. Breathlessness: mild, treat at home. Severe, treat in the hospital. General condition: good, treat at home. Poor, deteriorating, treat in the hospital. Level of activity is good, treat at home. If it is poor or confined to bed, treat in the hospital. Cyanosis, if present, you have to treat in the hospital. Worsening peripheral edema, if present, treat in the hospital. Level of consciousness is impaired, treat in the hospital. Already receiving LTOT, treat in the hospital. Social circumstances is good, treat at home. Living alone or not coping, treat in the hospital. Acute confusion, treat in the hospital. Rapid rate of onset, treat in the hospital. Significant comorbidity, example cardiac disease or diabetes, treat in the hospital. SaO2 less than 90% on air, treat in the hospital. Changes on chest X-ray if available, present, treat in the hospital. Hospital at home schemes and assisted discharge schemes are suitable alternatives. So in any case of exacerbations, if all of these signs are present, you have to decide whether the patient can be treated at home or in the hospital depending on this table. Start antibiotics. Use a broad spectrum antibiotic for 5 days. Example, amoxicillin 500 mg TDS, erythromycin 500 mg QDS, clarithromycin 500 mg BD, or doxycycline 200 mg on day 1 and then 100 mg OD. If sputum changes color or increase volume or thickness beyond its normal day-to-day variation, clinical signs of pneumonia is present, or consolidation on chest X-ray. So these are the antibiotics you can use in an exacerbation of COPD: amoxicillin, erythromycin, clarithromycin, doxycycline. Follow-up: reassess as necessary. If the patient deteriorates, reconsider the need for hospital admission. If not fully improved within 2 weeks, consider chest X-ray or hospital referral. Reassess the patient who have been admitted for 4 to 6 weeks after discharge. Assess their ability to cope at home. 1 in 3 are readmitted in less than 3 months. Reassess the inhaler technique and understanding of the treatment regimen. In severe cases, reassess the need for long-term oxygen therapy and or home nebulizers therapy. Check FEV1. Emphasize the potential benefit of lifestyle modification, smoking cessation, exercise, weight loss if obese. Rearrange ongoing regular follow-up. Arrange ongoing regular follow-up. So, next topic is lung cancer, page number 290. Referral for suspected lung cancer. Immediate referral or acute admission when there is stridor, superior vena cava obstruction, swelling of the face or neck with fixed raised JVP. Urgent referral to a team specializing in management of lung cancer if chest X-ray suggests lung cancer or more than 40 years with unexplained hemoptysis. Urgent referral for chest X-ray if more than 40 years, if more than 2 of the following symptoms are present, if more than 1, if concurrent or previous smoker or exposure to asbestos is present. So more than 40 years plus cough, fatigue, shortness of breath, chest pain, Weight loss, appetite loss. Consider urgent referral for chest X-ray if persistent or recurrent chest infections are present, finger clubbing, supraclavicular lymphadenopathy or persistent cervical lymphadenopathy is present, chest signs consistent with lung cancer, and thrombocytosis. Lung cancer is the third most common cancer in the UK, but most common cause of cancer death 22%. There are more than 39,000 new cases of lung cancer in UK each year. Incidence increases with age. 48% of lung cancer deaths each year occur in those aged more than 75 years. Historically, more common in males, although 45% of new diagnoses now are females. Types. Small cell lung cancer, 20% of all the cases, often disseminated at diagnosis, spreads to the liver, the bones, the brain, adrenals. Non-small cell lung cancer, 80% of all cases, mainly adenocarcinoma or squamous cell carcinoma. Not always smoking related. Screening. Current evidence does not support screening for lung cancer with chest radiography or sputum cytology. Frequent chest X-ray screening may be harmful. Screening with low-dose CT was found in one trial to decrease the number of people who died from lung cancer. But this trial has included very high-risk smokers and ex-smokers. However, there were high false positive rates. More research is needed about the use of CT screening in lower-risk individuals. So, how can you prevent smoking cessation? 90% of cancers are caused by smoking. The younger a person is when he starts smoking, the greater the risk of developing lung cancer. Risk also increases with the amount smoked, duration of smoking, and number of cigarettes smoked. Offer support and treatments to aid smoking cessation. Example: e-cigarettes, nicotine replacement, varenicline, and bupropion. Diet. Increased consumption of fruits, carrots, green vegetables may decrease the incidence, but there is no evidence that vitamin supplements are beneficial and they might be harmful. Presentation. More than 90% of symptoms at the time of diagnosis. Common presenting features are cough, chest or shoulder pain, hemoptysis, dyspnea, hoarseness, weight loss, finger clubbing, general malaise, distant metastasis, incidental finding on chest X-ray. Pancoast tumor, apical lung cancer plus ipsilateral hornell syndrome. Cause includes invasion of the cervical sympathetic plexus. Other features are shoulder and arm pain, brachial plexus invasion C8 to T12, plus hoarse voice or bovine cough, unilateral recurrent laryngeal nerve palsy, and vocal cord paralysis. Paraneoplastic syndromes. Ectopic ACTH production, CRD, hypercalcemia, hypercoagulability. Affect 10 to 20% of the patient with lung cancer, particularly small cell. Have a high index of suspicion and refer for specialist management if suspected. Management. Once the diagnosis has been confirmed, liaise with the chest physician, specialist lung cancer team, PHC team, and specialist palliative care services, Macmillan nurses. Active treatment options depend on the type and extent of the tumor and include surgery, radiotherapy, or chemotherapy. Follow up regularly. 70% die in less than 1 year. Long-term survival more than 10 years is currently only 5.5%. Palliative radiotherapy. Radiotherapy is a key component of symptomatic treatment for hemoptysis, chest pain, breathlessness due to bronchial obstruction, pain from bone metastasis, symptoms from brain metastasis. Radiotherapy may be combined with palliative chemotherapy, particularly for patients with non-small cell lung cancer. Mesothelioma 307, palliative care 1011. Colds and influenza. The common cold. Mild acute self-limiting upper respiratory tract infection more frequent in winter, more common in children. Adults have averaged on average 2 to 3 per year. Causes. Rhinovirus is the most common cause of cold. Coronavirus, influenza virus most commonly. Other include RSV, respiratory syncytial virus, enterovirus, adenovirus. 25% of colds have no identifiable cause. Infection with more than 2 viruses occur in 5% of the cases. Spread. Direct contact or droplet infection. Management. Advise patients to rest, take plenty of fluids. Paracetamol or ibuprofen for symptom relief. Usually symptoms resolve in less than 7 days for adults and less than 14 days for younger children. Mild cough may persist for more than 3 weeks. Complications. Exacerbation of asthma COPD, secondary infection, bronchitis, pneumonia, conjunctivitis, otitis media, sinusitis and tonsillitis. Acute bronchitis. Inflammation of the major bronchi often follows a viral upper respiratory tract infection, especially in the winter months. Symptoms include cough plus sputum, plus or minus sputum, breathlessness, and wheeze. On examination, the wheeze is often heard without other focal signs. Systemic features may be present, example sweats, fever, and myalgia. Management is a self-limiting illness, settles less than 3 weeks in a normally healthy people. Consider bronchodilators if wheeze is heard. Antibiotics may shorten the symptoms but weigh benefits against possible side effects. Side effects are increased community antibiotic resistance, medicalizing a self-limiting condition. If recurrent bronchitis, consider the diagnosis of COPD. Reasons to prescribe antibiotics immediately. So, in certain conditions, you have to prescribe antibiotics immediately. Investigate further or give antibiotics, amoxicillin 500 mg TDS for 5 to 10 days if systemically very unwell. Symptoms or signs of serious illness or complications like pneumonia. At high risk of serious complications because of pre-existing comorbidity, example, has a significant heart, lung, renal, liver or neuromuscular disease, immunosuppression, cystic fibrosis, or young children born prematurely, aged more than 65 with an acute cough, aged and more than two or of the following symptoms, or aged more than 80 years with an acute cough and more than one of the following, like hospitalization in the previous year, type 1 or type 2 diabetes, history of CCF, and current use of oral steroids. So in all these cases, you need to prescribe antibiotic, that is amoxicillin TDS 500 mg for 5 to 10 days immediately. Influenza. Sporadic respiratory illness in the winter months causing 600 deaths per year in non-epidemic years. Minor changes in viral protein causes annual epidemics. Pandemics occur with major shifts in surface proteins resulting in global side effects global effects as more people lack immunity. Causes are influenza virus A, B, or C spread by droplet infection, person-to-person contact, or contact with contaminated items. Incubation is 1 to 7 days. Presentation. Symptoms include fever, cough, sore throat, myalgia, and headache, usually self-limiting, with acute illness lasting 3 to 4 days. Some symptoms may persist for 1 to 2 weeks. Severity varies from asymptomatic to life-threatening complications. Most common complications are secondary bacterial infections, example otitis media, pneumonia, and bronchitis. Management. Rest, fluid, paracetamol, ibuprofen for fever, symptom control. Treat complications, antibiotics for chest infection, treatment of exacerbations of COPD or asthma. Antivirals. Oseltamivir or zanamivir are recommended to decrease the complications in adults and children if all of the following apply. National surveillance schemes indicating circulating influenza. The person is as at-risk group as indicated in box 10.1. The person presents with influenza-like illness and can start treatment within 28 hours or within 36 hours for zanamivir treatment in children of the onset of symptoms as per license indications. So the person must present early, like within 48 hours of onset of symptoms or 36 hours of onset of symptoms for getting antiviral treatment. Antiviral drugs may also be used for prophylaxis if national surveillance schemes indicate circulating influenza. That means there is a circulating epidemic or a pandemic going on. An at-risk person has not been immunized and has a close contact with a person with influenza symptoms, like a family member where one person has been diagnosed with influenza and the other person is just starting having symptoms. The person can start treatment within 48 hours after contact for oseltamivir or less than 36 hours for zanamivir. That says that you have to start it early, the antivirals. Influenza vaccination offered annually in the UK. All patients aged more than 65 years. Adjuvant vaccine to increase effectiveness. Children aged 2 to 17 years. Intranasal vaccine, attenuated vaccine program being phased across UK. All aged more than 6 months in high risk groups, which is given in the box. Quadrivalent inactivated vaccine less than 2 years. Intranasal live attenuated vaccine 2 to 18 years. Non-adjuvant vaccine age 18 to 65 years. Adjuvant vaccine in more than 65 years of age. Risk factors for severe disease with influenza. Age more than 65 years, diabetes, immunosuppression, BMI more than 40 kg per meter square, pregnant woman or less than 2 weeks postpartum, chronic respiratory, heart, renal, liver, neurological disease. High risk groups eligible for vaccination: diabetes, BMI more than 40, chronic respiratory, heart, renal, liver, neurological disease, immunocompromised or splenic patients, pregnant women, long stay care facility residents, nursing homes, household contacts of immunocompromised people, healthcare and social care workers, Hajj and Umrah pilgrims. Further information is given in the Green Book. Pneumonia in adults. Acute infection of lung parenchyma. Common condition affecting 0.5 to 1% of adults annually in the UK. Incidence increases with age and peaks in the winter. Mortality rate is less than 1% in those managed in primary care. 22 to 42% require hospital admission, where mortality increases to 5 to 14%. Presentation. Acute illness is characterized by symptoms of an acute lower respiratory tract illness, cough, plus or minus one of the other lower respiratory tract symptoms like purulent sputum, pleurisy, wheeze, pleuritic pain. New focal chest signs on examination: consolidation, decreased air entry, coarse crackles, or pleural rub. More than one systemic features: sweating, fever, shivers, aches, pains, or temperature more than 38 degrees. No other explanation for the illness. Elderly may present atypically, like off legs or acute confusion. Common causative organisms for pneumonia: usually bacterial, Streptococcus pneumoniae, H. influenza, more common among the elderly. Influenza A and B, annual epidemics during the winter months, 3% develop pneumonia. Mycoplasma pneumonia, 1.3%, less commonly in the elderly. Epidemics occur every 4 years in the UK. Gram-negative enteric bacteria, C. psittaci, 20% have a history of bird contact. S. Staphylococcus aureus, more common in the winter months, may be associated with viral infection like flu. Legionella species, more common in September, October, 50% related to travel. No cause identified is 45%. So these are the most common organisms. Tuberculosis, immunocompromised patients, vaccination for prevention, influenza vaccination, we have already read about it. Pneumococcal vaccination, we will read about it. Differential diagnosis of pneumonia: pneumonitis, secondary to radiotherapy, malignancy, pulmonary edema, pulmonary embolism, asthma, COPD exacerbation, tuberculosis. Investigations, often unnecessary in general practice, consider pulse oximetry used to assess the severity. If oxygen sat is less than 94% in air and the patient is hypoxic, he requires admission. Chest X-ray. If diagnostic uncertainty is there, symptoms not resolving, or risk of lung cancer, chest X-ray may lag behind clinical signs but should return to normal within 6 weeks after recovery. Persistent changes on chest X-ray more than 6 weeks after recovery require further investigations. Sputum culture. If not responding to treatment, if the there is weight loss, malaise, night sweats, or risk factors for TB, then you consider sputum culture. Ethnic origin, history of TB exposure, social deprivation, or the elderly. Request mycobacterium culture in that case. Blood. Full blood count, increase in white cell count, increase in ESR, acute and convalescent titers to confirm atypical pneumonia. Legionella, C. psittaci, and Mycoplasma pneumonia. Assessment of severity of pneumonia. What are the red flag signs and what are the intermediate features? Red flag signs are objective evidence of new altered mental state, increased respiratory rate more than 25 breaths, need new oxygen to maintain saturation more than 92% or more than 88% if COPD, systolic BP less than 90 or more than 40 millimeters below normal, increase in heart rate more than 130, not passed urine more than 18 hours if catheterized, passed less than 0.5 ml per kg per hour of urine, mottled or ashen appearance, cyanosis of the skin, lips or tongue, non-blanching skin rash. Intermediate features. History from a patient friend or relative of new onset altered behavior or mental state, history of acute deterioration of functional ability, increased respiratory rate in between 21 to 24 breaths, systolic BP in between 91 to 100, increase in heart rate 91 to 130, pregnant woman 100 to 130, or new onset arrhythmia, not passed urine in 12 to 18 hours, if catheterized and passed 0.5 to 1 ml per kg per hour of urine, and tympanic temperature is less than 36 degrees, that is hypothermia. These are intermediate features and these are the red flag features in case of pneumonia. Management. Consider the need for admission as per table 10.11. Admit as blue light emergency if any red flags features are present. If life-threatening infection or considerable delay more than 2 hours, consider administering antibiotics before admission. Consider admission. If any intermediate features are there, have a low threshold if more than 65 years, poor social situation, concomitant illness like heart failure, chronic lung disease, renal disease or liver disease, diabetes or cancer, impairment or immune function, immunosuppressant drugs, steroids or trauma, surgery or invasive procedure in the last 6 weeks. So these are the conditions in which if the patient has intermediate features, still you need to consider admission. If a decision is made to treat at home, advise them not to smoke, take analgesia, rest, drink plenty of fluids. If no intermediate features, give antibiotics for 5 days, example amoxicillin 500 milligrams TDS or doxycycline 200 milligrams on day 1 and then 100 milligrams OD, clarithromycin BD 500. Refer after 3 days, review after 3 days. If poor response, extend treatment to 7 to 10 days. So initially you give a treatment empirically for 5 days and then if after the third day there is poor response, you extend the treatment to 7 to 10 days. If any intermediate features are present, consider dual therapy with amoxicillin plus clarithromycin BD for 7 to 10 days or monotherapy with doxycycline for 7 to 10 days. Review within 3 days if poor response, then admit the patient. Complications. Require a specialist management. Refer for pleural effusion, may be reactive or empyema, pus in the lung cavity, lung abscess, presence with swinging fever and worsening pneumonia, septicemia, respiratory failure, metastatic infections, and jaundice. Tuberculosis. Caused by bacteria of Mycobacterium tuberculosis complex, 2015 there were 10.4 million new cases worldwide and 1.8 million deaths. In UK, 6240 cases were notified in 2015 and accounted for 300 deaths. Risk factors in the UK. Born in high prevalence areas like India, Pakistan, Nigeria. Active TB contact in the same household. Close contacts at school or work. Previous specially incomplete TB treatment in 2013. 7% of repeated TB cases had a diagnosis of TB more than 12 months previously. Immunosuppression by medications like steroids, chemotherapy, or comorbidities, HIV, diabetes. People living with HIV accounted for 1.2 million new cases in 2015 worldwide. Smoking, alcohol, and drug misuse. Social factors. More 70% of all patients with TB in the UK were resident in the 40% more deprived areas. At particular risk are the homeless, institutionalized people, and people living in overcrowded conditions or in prisons. Prevention. The BCG is a live attenuated strain of bacteria derived from M. bovis. BCG vaccination provides immunity lasting less than 15 years to 70 to 80% of the recipients. It is given as an intradermal injection to the left upper arm. Target groups are all infants living in areas where TB incidence is more than 440 in 1 lakh and infants whose parents or grandparents were born in a country with TB incidence of more than 40 per 1 lakh. So, BCG vaccine is given at birth if any of the conditions are there, not to all the infants born in UK. So, all infants living in areas where incidence is more or whose parents or grandparents were born in a TB endemic country, previously unvaccinated new immigrants from countries where there is a high prevalence of TB, occupational risk, healthcare workers, veterinary staff, and prison staff, contacts of known cases or those living in or working in high prevalence countries for extended periods, generally more than 3 months. Do not give other immunization to the same arm for 3 months. Screening. TB is a notifiable disease. After notification and contact tracing is initiated, usually through chest clinics, screening may be done with tuberculin test or interferon gamma release assay depending on the scenario. Tuberculin skin test. Standard in UK is the Montauk's test, useful to detect previous exposure to the organism or BCG vaccination by provoking an immune reaction. A purified protein derivative of tuberculosis is injected intradermally in the forearm. Response is read after 48 to 72 hours. Test can be suppressed by Hodgkin's disease, viral infections, sarcoidosis, glandular fever, corticosteroid therapy. Live viral vaccines do not do a tuberculin test within 4 weeks after vaccination. Immunosuppressant treatments of or diseases including HIV. If a patient has a positive tuberculin test, do not give BCG vaccination. Primary tuberculosis. Initial infection transmitted by droplet infection. A lesion forms usually pulmonary which drains to local lymph nodes. Immunity develops and the infection becomes quiescent. May be asymptomatic or include fever, night sweats, persistent cough plus sputum, hemoptysis, pneumonia, pleural effusion, anorexia, weight loss or erythema nodosum. So primary TB can be silent or it can have these symptoms. Tuberculin testing and interpretation of results. So once the dose of tuberculin is injected into the forearm, after 48 to 72 hours when we are supposed to check the result, the diameter of induration we check less than 6 millimeters, then the result is negative. Suggests there is no TB infection. Beware of false negatives. Previously unvaccinated people may be given BCG provided there are no contraindications. 6 to 14 mm positive. Should not be given BCG, may be due to previous TB infection or BCG or exposure to non-tuberculous mycobacteria. More than 15 is strongly positive. Suggests TB infection or disease, refer for investigation. Investigations and management. Chest X-ray in tuberculosis, 3 sputum samples for culture and microscopy for acid-fast bacteria. Refer for a TB specialist service for diagnosis and ongoing management. Post-primary TB. So initial was primary TB and then this is post-primary TB, that is reactivation of a primary infection. Initial lesions usually in the upper lobe of the lungs progress and fibrose. Other sites may develop disease. Multiple small lesions throughout the body result in miliary TB and is common in immunocompromised patients. Symptoms and signs related to organs infected. In all the cases, refer for specialist treatment. Extrapulmonary disease sites are the CNS, the spine, rarely or other bones or joints, pericardium, the lymph nodes, the peripheral cold abscess, and miliary tuberculosis. Treatment. Always refer to chest clinic. 10% are resistant to first-line antibiotics. Specialist management will involve antibiotic drug treatment with combination regimens usually for 6 months of isoniazid and rifampin with pyrazinamide and ethambutol for the first 2 months. All have potentially serious side effects and need monitoring. Risk assessment for drug-resistant TB and HIV infection. Care, coordination and allocation of key worker to monitor treatment, concordance, side effects and clinical response. Directly observed treatment therapy is used in high-risk groups, DOTS, example homeless patients, to ensure concordance. Medications are taken under observation. Contact tracing. Other respiratory infections are mycoplasma. Mycoplasma causes epidemics of lower respiratory tract infection every 3 to 4 years. It is spread by droplet infection. Incubation period is 12 to 14 days. It's very long. Presentation: dry, persistent cough plus or minus arthralgia. Chest X-ray shows bilateral patchy consolidation. Infection is confirmed with serology. Management: clarithromycin 500 mg BD for 2 weeks or doxycycline 100 mg daily for 2 weeks. Relapse is common. Severe infections may require hospital admission. So here it's a long course, 2 weeks course of clarithromycin or doxycycline. In mycoplasma, respiratory chlamydial infections, chlamydia pneumoniae or chlamydia psittaci. Chlamydia pneumoniae accounts for 6 to 19% of community-acquired pneumonia, especially in children and young adults. Clinically, indistinguishable from Mycoplasma pneumoniae. Treat with doxycycline 100 to 200 milligrams per day or clarithromycin 500 milligrams VD for 2 weeks or azithromycin 500 milligrams OD for 3 days. Infection with Chlamydia psittaci. Infection by animals infects many animals, but human infection is closely related to contact with birds. Treat as for Chlamydia pneumoniae, pertussis or whooping cough. Caused by Bordetella pertussis, presentation incubation period is 7 to 10 days. Symptoms are catarrhal stage. Symptoms and signs of upper respiratory tract infection last 1 to 2 weeks. Coughing stage increasingly severe. Paroxysmal cough with spasms of coughing followed by a woof, associated with vomiting, cyanosis during coughing spasms, plus or minus exhaustion. Last at least 4 to 6 weeks. It's called 100-day cough. Then cough improves over 2 to 3 weeks. Chest is clear in between the coughing bouts. Investigation. Microscopy and culture of the nasal swab. Special swab and culture medium is available from the laboratory. FBC lymphocytosis. Management. Macrolide antibiotics, clarithromycin, erythromycin or azithromycin are recommended if onset of cough was in the last 21 days. So initially only if you give antibiotics it is useful, not after that. Complications are pneumonia, bronchiectasis, convulsions, subconjunctival hemorrhages and facial fatigue. Prevention. How to prevent pertussis? Proven contacts. Treat with clarithromycin or erythromycin. Childhood vaccination. Personal or family history of febrile convulsions, family history of epilepsy and well-controlled epilepsy are not contraindications. Give advice on fever prevention. Defer vaccination if any undiagnosed or evolving neurological condition or poorly controlled epilepsy until the condition is stable. If in doubt, seek a specialist pediatric advice. Vaccination in pregnancy. Offered from 16 to 32 weeks gestation in the UK to increase the passive immunity in newborn babies. Combination vaccine containing inactivated polio, tetanus and diphtheria as well as pertussis is recommended. If missed, can be given until the female goes into labor. 16 to 32 weeks. Now they are giving a combination of polio, tetanus, diphtheria as well as pertussis. So it's a 4 quadrivalent vaccine is given until the female goes into labor. Pertussis immunity wanes after vaccination. Do not rule out the possibility of pertussis just because the patient has been vaccinated. So as for childhood vaccinations, they are saying that if there is personal or family history of febrile convulsions or family history of epilepsy or well-controlled epilepsy in the person, they are not contraindications to vaccination. Okay, only you have to give fever prevention. But if the patient is having undiagnosed evolving neurological condition or poorly controlled epilepsy, then the vaccination should be deferred until the patient is stable or epilepsy is controlled. Aspergillosis. Spores of Aspergillus fungi present in the soil and decaying vegetation can be inhaled at any time of the year but reach peak levels in autumn or winter. Inhaled spores colonize the bronchial mucosa and nasal sinuses. Presentation. Asthma can present as asthma. Allergic bronchopulmonary aspergillosis presents with episodes of eosinophilic pneumonia characterized by wheeze, cough, fever and malaise throughout the year, but worse in late autumn. Chest X-ray shows fleeting lung shadows cleared by expectorating firm brown plugs of mucus. Untreated upper lobe fibrosis and proximal bronchiectasis. Invasive aspergillosis occurs in immunocompromised. Aspergillus disseminates from the lung to the brain, the kidneys and other organs, carrying very poor prognosis. Aspergillus sinusitis, nasal congestion, headache and facial pain. Aspergilloma, growth within the existing lung cavities, example from previous TB or sarcoidosis. A ball of fungus forms. Chest X-ray shows a round lesion with an air halo above it. Occasionally results in hemoptysis. Management, refer for specialist management. Pneumocystis jirovecii, PCP. May be classified as a protozoan or fungus causing pneumonia in immunocompromised patients. The presentation is there is fever, breathlessness, tachypnea, dry cough, respiratory failure or cyanosis. Investigations: chest X-ray is normal, ground glass appearance or ground glass appearance. Sputum culture may be diagnostic. Management: if suspected, refer for specialist care. Treatment is with cotrimoxazole or dapsone. Prevention: prophylactic antibiotics, usually cotrimoxazole, are given to AIDS patients with CD4 counts less than 200 cells per millimeter cube. Novel coronavirus infections include SARS, sudden acute respiratory syndrome, MERS, Middle East respiratory syndrome, and COVID-19 coronavirus disease. Spread is by direct contact with the infected individual or contaminated surface or aerosol. Incubation period is 2 to 14 days, mean is 5.5 days. Two stages. There is a prodrome of fever more than 37 degrees, malaise, headache, and myalgia. Respiratory phase develops after 3 to 7 days, dry cough and breathlessness. Other symptoms: watery diarrhea, conjunctivitis, upper respiratory tract symptoms, example rhinitis, sore throat. Asymptomatic patient must still spread the virus. More than 95% recover after 7 to 10 days, but 1 to 2% progress to respiratory failure or secondary complications like pneumonia. If mild symptoms, manage at home. Patient must self-isolate for more than 7 days or until full recovery. If breathless at rest, peripheral oxygen saturation less than 92% on air, circulatory compromise or persistent fever more than 7 days, so normally the fever should come down in 3 days, but if it's persisting more than 7 days, admit as an acute medical emergency. Personal contacts of patient with suspected or confirmed infection must self-isolate for 14 days. A COVID-19 vaccine is likely to be available by 2020-21. So it is available. Always wear personal protective equipment when assessing or managing patient with suspected coronavirus infection and pre-warn the ambulance or hospital staff if transferring to hospital. Cystic fibrosis and Cartagena syndrome. Cystic fibrosis, the most common inherited disorder in the UK, prevalence is 1 in 2,500. Around 10,800 people in the UK have cystic fibrosis. Median survival has increased dramatically and is now more than 40 years, but about 7,500 CF patients in the UK and 66,000 are less than 25 years old. Genetics. Results from mutation of a single gene on chromosome 7, cystic fibrosis transmembrane conductor regulator, CFTR gene, essential for salt and water movement across the cell membranes. This causes thickened secretions. More than 2,000 different mutations have been described. Autosomal recessive inheritance results in 1 in 4 chance of a child with a cystic fibrosis if both parents are carriers. 1 in 25 adults in UK are cystic fibrosis carriers. Most common in Caucasians, rare in people of Afro-Caribbean origin. Screening. Several possibilities. It's an autosomal recessive condition. So if the parents are carriers, then 1 in 25% of the 1 in 4 chance that offspring will have cystic fibrosis if both parents are carriers. Screening. Several possibilities. Preconception screening. Buccal smears to karyotype prospective patients. Antenatal screening. Chorionic villus sampling at 10 weeks for parents with an affected child already or where both parents are positive on karyotyping. Neonatal screening. Common problems associated with cystic fibrosis are diagnosis. Screening. If clinical suspicion of cystic fibrosis, refer to pediatrics. A positive sweat test more than 60 millimoles per liter on 2 occasions is diagnostic. This is sweat chloride testing. A positive sweat chloride testing more than 60 millimoles per liter on 2 occasions is diagnostic as increased potential difference across the nasal respiratory epithelium. As is increased potential difference across the nasal respiratory epithelium, an elevated sodium level may be found on the sweat test as well as increased chloride sodium ratio of more than 1. Chloride sodium ratio of more than 1. Management. Cystic fibrosis is a multi-system disease requiring a holistic approach to care which aims to maintain patients' independence, improve the quality of life and extend life expectancy. A multidisciplinary team is in a specialist cystic fibrosis center is best placed to achieve this. Patients usually have direct access. Management involves treatment of the lung disease, for example, with exercise, physiotherapy, antibiotics, and mucolytics. Management involves treatment of the lung disease with exercise, physiotherapy, antibiotics, and mucolytics, maintaining good nutritional state, pre-meal oral pancreatic enzymes, high-calorie diet, fat-soluble vitamin supplementations. High-calorie and high-fat diet is now recommended. Treatment of complications like diabetes and osteoporosis. Cartagner syndrome. Cartagner syndrome or immotile cilia syndrome is an autosomal recessive inherited condition, same like cystic fibrosis, results in abnormal structure and function of the cilia, consists of a combination of bronchiectasis, chronic sinusitis, and male infertility plus situs inversus transposed heart and abdominal organs. Bronchiectasis, chronic sinusitis, and male infertility plus situs inversus or transposed heart and abdominal organs. Otitis media and salpingitis are frequent. Specialist treatment is supported. So this is this is a figure showing features of cystic fibrosis. Let us see. Head to toe, behavior and psychological problems, nasal polyps in liver, abnormal bile, intrahepatic biliary stasis and gallstone formation resulting in chronic liver disease, biliary colic, cholecystitis or biliary strictures. In the lungs, increased viscosity of the secretions, bronchiectasis, airway inflammation and bronchoconstriction, infection, pneumothorax, Aspergillus fumigatus and allergic bronchopulmonary aspergillosis causes recurrent episodes of eosinophilic pneumonia, cor pulmonary or respiratory failure. Pancreatic disease, pancreatic insufficiency leading to malabsorption in 85% of the patients, acute pancreatitis, type 1 diabetes mellitus. Bowel disease, meconium ileus, distal ileus obstruction syndrome, meconium ileus equivalent, intussusception, rectal prolapse due to bulky stools. Excuse me. Infertility. Male infertility and female subfertility have a low threshold for referral. Musculoskeletal problems. Osteoporosis in 1 in 3 adults with cystic fibrosis, hypertrophic pulmonary arthropathy, cystic fibrosis arthropathy, and sweat and salivary glands secrete fluids with increased sodium content. Other problems are vasculitis, failure to thrive in 50% children with cystic fibrosis. Interstitial lung disease, also known as diffuse parenchymal disease, comprises of more than 200 different diseases in which inflammation affects the alveolar wall leading to fluid and in the alveolar spaces. Presentation: increased dyspnea and cough, more rarely a wheeze, pleurisy or hemoptysis, may present incidentally with changes on chest X-ray. Further assessment: history of the condition, acute, chronic, episodic, severity, exercise tolerance, possible causes, smoking, hobbies and occupation, usual environment, lives on a farm or travel, past medical history, particularly rheumatological symptoms and immunosuppression, example HIV, and family history, and drugs. Examine looking for fine inspiratory crackles in the chest, evidence of systemic disease, example fever, rashes or other skin changes, eye signs, particularly red eye, hepatomegaly or splenomegaly, arthritis, pulse oximetry, decreased peripheral oxygen saturation. Investigations in interstitial lung disease. Chest X-ray, diffuse shadowing, urine dipstick for protein and blood, FBC, ESR, liver and kidney function test, thyroid function test and autoimmune profile. Lung function test usually shows restrictive picture in interstitial lung disease, rarely no abnormalities or obstructive picture. Classification is given in 10.13. We will see that hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, farmer's lung or bird fancier's lung, inhaled particles, fungal spores, avian proteins cause allergic reaction in the lungs or of hypersensitive individuals, may present as an acute or chronic reaction, or both may occur together. Acute reaction is 2 to 4 hours post exposure, consists of fever, malaise, dry cough and shortness of breath. Chronic reaction, malaise, weight loss, exertional dyspnea, fine crepitation in both the lungs. Investigations, blood. FBC, increased neutrophils, acute reaction and increased ESR in acute reaction. Chest X-ray may be normal or show typical changes, shadowing, widespread small nodules or ground glass appearance. Diagnosis based on history and high resolution CT scan findings. Serum precipitants to provoking factor are found in 90%. Management. If possible, prevent further exposure to the allergen. In all cases, refer for specialist advice. Treatment is usually with steroids. If occupational exposure may qualify as an industrial disease and be eligible for compensation. So, this is the table showing the classification of interstitial lung disease. Classification: acute. Causes are infective, bacterial, tuberculosis, viral, chickenpox or measles, fungal, allergy, drug, fungi, helminths, toxins, drug, gases, hemodynamic, left ventricular failure, fluid overload, renal failure, vasculitis, adult respiratory distress syndrome. All of these cause interstitial lung disease. Episodic, eosinophilic pneumonia like allergy, bronchopulmonary aspergillosis, vasculitis, eosinophilic granulomatosis, polyangiitis, formerly called Church-Strauss syndrome, hypersensitivity pneumonitis, cryptogenic organizing pneumonia. Chronic due to occupational or environmental exposure like drug-induced, asbestos, silicosis, coal workers pneumoconiosis and siderosis. Iron. Farmer's lung, bird fancier's lung, radiation, drugs, nitrofurantoin, sulfasalazine, gold, penicillamine, aspirin, amiodarone, bleomycin, methotrexate, hydralazine, heroin, methadone or oxygen. All of these cause interstitial pneumonia, interstitial lung disease. All these drugs. Chronic with evidence of systemic disease. Connective tissue diseases like rheumatoid arthritis, Sjogren syndrome, SLE, neoplastic like lymphoma, vasculitis, granulomatosis, polyangiitis, formerly called vaginous granulomatosis, good pasture syndrome and sarcoidosis. Inherited disorders like tuberous sclerosis, neurofibromatosis, miscellaneous like HIV, inflammatory bowel disease, post-marrow transplant, bone marrow transplant and amyloidosis. All of these cause interstitial lung disease. Chronic without evidence of systemic disease are idiopathic pulmonary fibrosis and chronic aspiration. Advise all patients with interstitial lung disease to stop smoking. This results in better prognosis for the interstitial lung disease. Furthermore, patients with chronic interstitial lung disease are at substantially increased risk of lung cancer. Page number 304. Idiopathic pulmonary fibrosis. "6,000 people are diagnosed every year in the UK, males more than females. Incidence increases with age. 85% diagnosis made by people more than 70 years. Progressive condition of unknown cause with insidious onset can only be diagnosed if other causes of interstitial lung disease have been excluded and symptoms present for more than 3 months. Risk factors for idiopathic pulmonary fibrosis are smoking, environmental exposure, example metal dust, animal dust, chronic viral infection like Epstein-Barr virus, hepatitis C, and GORD. Presentation: progressive exertional dyspnea, dry cough, clubbing more than 50% of patients, fine velcro-like crepitations, malaise, weight loss, central cyanosis and right heart failure, advanced cases. So any lung condition causes a right heart failure. Investigations: chest X-ray, diffuse shadowing although may be normal, lung function test, restrictive picture. Differential diagnosis could be a left ventricular failure, COPD, inhalant exposure like oxygen or nitric oxide, radiation exposure, Other causes of lung fibrosis like dust exposure, coal, asbestosis, silica, farmer's lung, bird fanciers lung. So you have to rule out all of these before coming to a diagnosis of idiopathic pulmonary fibrosis. Management. Refer to a respiratory physician for diagnosis, advice on management. Treatment where appropriate is with oral steroids plus azathioprine. Pulmonary rehabilitation may be helpful. Lung transplant is the last option. Most patients have poor prognosis with a median survival of 3 years. A subgroup of fibrotic non-specific interstitial pneumonia (NISP) has substantially better prognosis with more than 50% surviving 5 years. Patients with idiopathic pulmonary fibrosis have 10 times increased risk of lung cancer. This risk is multiplicative with that of from smoking. So patients with IPF who smoke 20 cigarettes a day may have a 200 times increased risk of lung cancer compared with those of non-smokers without IPF. Sarcoidosis. Sarcoidosis is a multisystem inflammatory disease of unknown cause characterized by non-caseating granulomas. Annual incidence is in the UK is 7 in 1 lakh, typically present with lung granuloma in a young adult, females more than males. Non-respiratory manifestations of sarcoidosis has fever, malaise, erythema nodosum, lupus pernio or blue-red nodules on the nose, face or hands. Scar infiltration, enlarged lacrimal glands, hypopion, uveitis, arthralgia, hepatosplenomegaly, arrhythmias, heart failure, pericardial effusion, cranial or peripheral nerve palsy, seizures, hypercalcemia, renal stones and lymphadenopathy. Acute sarcoidosis or Lofgren syndrome is acute sarcoidosis, polyarthralgia, erythema nodosum, swinging fever, bilateral hilar lymphadenopathy on chest X-ray. So acute sarcoidosis, also called as Lofgren syndrome, has polyarthralgia, a swinging fever, erythema nodosum and bilateral hilar lymphadenopathy on chest X-ray. Insidious onset. Chest X-ray shows hilar lymphadenopathy, incidental finding in 30 to 50% patients. If symptomatic, usually present with tiredness, malaise, weight loss or arthralgias. 15% have lung symptoms with gradual onset of progressive exertional dyspnea and dry cough. Management. Refer any patient with bilateral hilar lymphadenopathy for further investigation. For patients with confirmed sarcoidosis, specialist management is needed. Steroids are the first line management but should only be used if progressive disease is present on imaging or lung function testing. Significant symptoms are there, extrapulmonary disease requiring treatment. Rarely, if steroids are not controlling the disease progression or symptoms, methotrexate will be added. So in case of idiopathic pulmonary fibrosis, the first line treatment is prednisolone plus azathioprine. Whereas in case of sarcoidosis, it is steroids, and if steroids are not useful, then methotrexate. Inhaled steroids may be helpful to control cough but does not influence the disease progression. For patients with severe symptoms, pulmonary rehabilitation may be helpful. Lung transplantation may be considered for patients with end-stage pulmonary sarcoidosis. Prognosis. Variable natural history. So predicting the course of a disease and prognosis is difficult. Spontaneous remission occurs in 55 to 90% of patients with stage 1 radiological disease and 40 to 70% with stage 2 disease, 10 to 20% stage 3 disease. Most remissions occur in the first 6 months of life. Mortality ranges from 1 to 5% due to pulmonary myocardial or CNS involvement. Occupational lung diseases we'll see in page 306. So here we are at occupational lung diseases. Exposure to gases, vapors or dust at work can lead to lung disease. Coal workers pneumoconiosis, 90% of all the compensated industrial lung diseases in UK. Pneumoconiosis means accumulation of dust in the lungs and the tissues reaction to its presence. Incidence is related to total dust exposure It divides into simple pneumoconiosis, deposition of coal dust in the lungs, graded on chest X-ray appearance. Grading determines whether the disability benefit is payable in UK. Effect on lung function is debated. Predisposes to progressive massive fibrosis. Progressive massive fibrosis, round fibrotic masses several centimeters in diameter form in the upper lobe of the lungs, presents with exertional dyspnea cough, black sputum, and eventually respiratory failure. Symptoms progress or even start after exposure to coal dust has ceased. Lung function tests show a mixed restrictive and obstructive picture with loss of lung volume, irreversible airflow limitation, and decrease in gas transfer. So there's a mixed restrictive and obstructive picture of with loss of lung volume and irreversible airflow limitation and decreasing gas transfer. Asbestosis. Before legislation banning its use, exposure was widespread and occurred particularly in naval shipyards and power stations. Effects of asbestos exposure given in table 10.14. Consider diagnosis in relatives who come into contact with asbestos while washing clothes, etc. too. They can claim compensation if affected. Okay. Silicosis. Uncommon. Affects the stonemasons, pottery workers, workers exposed to sandblasting, and fettlers who remove sand from metal casts. Caused by inhalation of silica. Chest X-ray appearance is distinctive, presents with exertional dyspnea and cough. Lung function test. As for progressive massive fibrosis, associated with increased risk of lung cancer and tuberculosis. Byssinosis affects cotton mill workers. Symptoms include chest tightness and cough and breathlessness. Starts on day 1 back at work after a break, that is Monday sickness, with improvement as the week progresses. Chest X-ray is normal in byssinosis. Berylliosis, rare, long latent period, affects the workers in the aerospace, nuclear power and electric industries and their close relatives, present similarly to sarcoidosis. Iron cirrhosis, barium barytosis, and tin stenosis and dust inhalation. So this is iron dust inhalation, barium inhalation, tin inhalation. Results in dramatic dense nodular shadowing on the chest X-ray, but effects on the lung function and symptoms are often minimal. So there is dramatic dense nodular shadowing on the chest X-ray, but effects on lung function and symptoms are minimal. Only shadowing is there. Occupational asthma. More than 200 industrial materials called occupational asthma accounts for 70% of all adult asthma. Important causes are recognized occupational diseases in UK. Patient may be eligible for statutory compensation if they apply less than 10 years after leaving the occupation in which asthma developed. Suspect if a patient has symptoms which improve on days away from work or holiday. Hypersensitivity, pneumonitis or farmer's lung. Management. In all the cases, refer to a respiratory physician for confirmation of diagnosis, essential if seeking compensation, and advice on management. So conditions caused by asbestos exposure. So benign pleural effusion usually occurs less than 20 years after exposure. Increasing dyspnea, pleuritic pain, refer for drainage of effusion, may be recurrent and require pleurodesis. Bilateral diffuse pleural thickening follows light or moderate exposure to asbestos, may progress even in the absence of further exposure. Defined as pleural thickening more than 5 mm thick covering more than 1/4 of the chest wall. Symptoms include exertional dyspnea. Lung function tests show a restrictive picture. Treatment is symptomatic. Asbestosis follows heavy exposure after 5 to 10 years, presents with a progressive dyspnea, finger clubbing, basal end respiratory crackles, chest X-ray, honeycomb lung, diffuse streaky shadowing, lung function tests, severe restrictive defect and decreased gas transfer. Treatment is symptomatic. So in asbestosis, there is finger clubbing and basal end respiratory crackles. And on chest X-ray, there's a honeycomb lung. Lung function test, restrictive pattern, and treatment is symptomatic. Mesothelioma can even follow light exposure to asbestos. 20 to 40 years time lag between exposure and the appearance of disease. Patients presents with increasing shortness of breath and pleuritic pain. Examination in chest X-ray reveal unilateral, rarely bilateral effusion. There is no effective active treatment. Palliative care 10-11. Median survival is 2 years from diagnosis. Asbestos-related lung cancer. Patient exposed to asbestos who have evidence that exposure, pleural plaques, bilateral pleural thickening, or asbestosis have an increased bronchial carcinoma, risk of bronchial carcinoma, usually adenocarcinoma. Smokers exposed to asbestos have 5 times increased risk compared to non-smokers exposed to asbestos. Manages lung cancer. So asbestosis related lung cancer eligible for industrial injuries benefit in the UK. Benefits, notification and compensation can be seen on page number 90. Snoring and obstructive sleep apnea. So that's all for today. We will continue from page number 308 tomorrow. Thank you friends. Have a good day.